So in step 2 of the protocol, the patient can say, you know, the mouth taping, the nasal dilator, and the mandibular orthotic, I love it. I'm sleeping better, feeling better. My bruxing has gone away. My muscle pain has gone away. Whatever their symptom happens to be, tends to be clearing up. But they also may say, I don't like this at all. And in fact, about 50% of your patients are going to have more of a compromised airway and more symptoms associated with it. I'm bruxing more against this. I find it on the floor, not in my mouth. In those patients that either don't resolve or get worse, you move from step 2 to step 3. We're going to be making them now an anterior repositioning appliance, one that moves the lower jaw forward approximately 3 millimeters. Now here's the nice thing about the protocol, and it happens in all the steps. In the past, when I would make a patient a night guard and invest in that night guard with a laboratory and all the time required to do that, I would keep trying to adjust it over and over again until either the patient got better maybe, or they went away. I never would say, you know, that one just doesn't seem to work. Let's try a different design. The beauty of the provisional nature of this is you do that. Step 2 doesn't work, let's go on to step 3. In step 3, we're going to use exactly the same amount of vertical opening, but we're going to move the jaw a little forward. And there we know that many patients are going to find resolution. For patients that don't resolve at step 2, we move to step 3 of the protocol. Step 3 calls for an anterior repositioning splint. Now you may not have heard of anterior repositioning splints, although there have been significant numbers of studies done in dentistry comparing them to our step 2 splint, the flat plane or stabilizing splint. And in the vast majority of those studies, this is an incredibly successful splint for our TMD patient, our patient that is very sympathetically active. What it calls for is taking that mandibular splint that we made at step 2 and allowing the mandible to protrude 3 millimeters. So I have a flat splint. How do I keep the mandible protruded 3 millimeters? What we're going to do is add some softened beads in the back of the splint that when they harden, they provide a guide for the patient to bite into. The thing that I don't want to do is alter the vertical dimension. Each step of the protocol should make one change, not multiple changes. So step 2 of the protocol opened the vertical dimension of the bite, creating more oral volume. Step 3 of the protocol, movement of 3 millimeters with no additional opening is what we're trying to achieve. So the things that you need for step 3 of the protocol, you need a patient mirror. Once again, we need to be able to get in the mouth without deflecting any of the material. You need a measuring tool. I happen to like to use a perio probe, although a ruler will work. A pencil in order to mark the anatomy of the teeth when we're going to make the bite registration. We need a burr to adjust on the MyTap appliance. Obviously, we need the lower appliance that you've already made. We're going to make that in step 2 and transition it to a different type of appliance in step 3. 3 things that you didn't have in the operatory before. You're going to need a patient mirror, and the patient mirror is going to be used to guide the patient into the proper bite. You're going to need a torch in order to heat your MyTap appliance. And finally, you're going to need thermocryl beads. These thermocryl beads are manufactured by the same makers of the MyTap appliance. The thermocryl beads that I prefer happen to actually have a beige color. The beige color allows me to differentiate it from the clear or white color of the MyTap appliance. So it's very clear where I've added some beads to my appliance. The goal of step 3 is to go from a mandibular splint to a mandibular advancing appliance using the beads to hold the jaw in a more protruded position. The way I do it is I use a periodontal probe. I have the patient bite into their maximum intercuspal bite, and I measure from the central incisor to the splint. Now in many cases, our patient, when they bite down, will already be on the splint, so we can then move forward from there. But in this case, the distance between the mandibular splint and the central incisor is actually 3 millimeters. So When I have her protrude forward until she's end to end with the front of the splint, we know we've reached that 3 millimeter distance. So protrude your jaw forward, move, move, move. Well, when she gets to the splint, what happens is she actually hits on those two edges that are protective of the rod that comes through the tap appliance. I showed you that when the stick comes off the lower, there are some protective guides made of hard acrylic that's on this splint. Many times as we protrude forward, the patient's central incisors will catch on those. That means the back teeth come further away from the splint, and we would alter the vertical dimension. So what I need to do is actually take a burr and trim those away. Can you take out the splint for me? You see, as she protruded and got on those spots, what we found is the back teeth actually came off the splint. Just take an acrylic burr that you trim any of your night guards with and take down those two areas. Side forward. Okay, stay there. All right, now when she slides forward into an end-to-end position, there's no more contact with those protective pieces of acrylic on the lower appliance. So, how do we get a patient to bite 3 millimeters protruded into the position? Well, one way of doing it is actually to put a softened bead in the back and then have them slide and stop them in position. But what we found is it actually drags the material. And those of you that have ever done bite registrations know that if a patient's moving around as the bite registration is starting to set, it'll drag, it won't give you good detail. So what we're going to do here is we're actually going to have her move into that position, hold her there, mark where the central incisors are, and then have her practice closing into that position where she hits the spot every single time. Now I'm going to mark her central incisors. If she was extremely class 2, let's say there was 5 millimeters, 6 millimeters between the lower splint and her central incisors, when she moved her jaw forward 3 millimeters, she still wouldn't have anything to mark on the anterior teeth, the central incisors. So you find the first tooth that makes contact with the splint and make the marks on the side. Maybe the canine, maybe the first bite that you actually mark on those patients so they can practice actually closing into the position. In this case, the central incisors are going to be used, so I'm going to take a pencil. It works better than a Sharpie or anything else that I found. We're going to have her bite in her maximum cuspal bite, and what I'm going to do is mark the midline for her. Why? Because when she slides forward, I want her to stay on the midline. So as I'm asking her to move forward, we're going to continue to make sure it's a straight protruded path. So let me have you slide forward until I tell you to stop. Move forward, forward, a little bit more, and stop right there. Okay? I need to make sure the midlines are still aligned correctly. A little bit to the left. There we go, perfect. Now I'm going to mark the outline of her central incisors for her. I'm just putting the pencil right along the incisal edges. That'll create marks in the mouth that she can actually now take a mirror, a patient mirror, hold it there, and practice closing every time until she can hit those marks with her central incisors. So take your mirror, hold it to the side here, and then practice opening, open for me, and close on those marks, not sliding. Close on the marks. So we are looking for to be able to repeat that closure pattern so that when I put some softened material, she's not having to hit and slide around at all. I want it clean into the marks where it can be held in place so that we don't get any deflection in the material. Good. Feel comfortable doing that? Mm-hmm. And find the marks every time, it looks like. All right? Good. So what I'm going to do is I'm going to take this splint out of your mouth, I'm going to add some softened material in the back. I'm going to come over and we're going to put it in place, and then I'll have you turn and watch the mirror and close into the marks and hold. Once you hold, then we'll hold for 4 minutes in that position until the material sets. Now, just remove it for me. Thank you. Okay, so the softened material are these Thermacryl Plus beads. You need a flame to heat the appliance, and you're once again going to need hot water. But you do not want to put your appliance back in the hot water, or it's going to change the fit for the patient. So the only thing that's going to go in the hot water is the thermoplastic beads. So adding water to your bowl. The mistake most people make is using too many beads. About a teaspoonful is all you're really going to need to add to the appliance. And when these get hot, they actually don't turn colors the way that the MyTap did. What they'll do is get soft and be able to be grabbed together and turned into a putty. I like to take that putty and thin it out, and create about the width of what the back end of the MyTap is. So about the same width. Now we're going to have it on both sides, so I tear it in half and then put it back into the bowl. Now it's ready to go. Now we've somehow got to get this putty to stick onto the appliance. And we've tried adhesives, we've tried all different things. The absolute easiest and best way to do it is to flame the top of the appliance very lightly, very quickly. The more you flame, the more you have a risk of actually melting the thermoplastic on the inside, which would change the fit of the appliance. The other thing that would happen is the more you flame, the harder the beads are going to bind. At steps 4 and 5, you actually have to take the beads off. So we want to make sure that it's accessible to where we can get it off. We don't have to harm the appliance. So I use this flame, I lightly go across, and that should be plenty. Take the beads out, place them on the appliance. And you don't want to cover up anteriorly. Remember, we made marks for our patient to see where she's supposed to close into. If you bring the beads all the way to the front, she loses the marks. So you're ready to go to the mouth now. Place it in the mouth, lock it down. And now it's the patient's responsibility to, on closure, find the marks, a little more protruding, and close into the marks and hold. Good. We need 4 minutes for the material to reach its completed set, at which time we're going to take it out and trim it up. When you go to the lab to trim the step 3 appliance, a couple things to note. First of all, we want to be doing most of the work with our Bard Parker blade, our 25 blade. Second thing is that you want to see the patient, if possible, biting down and all the way through to the appliance again. So there are multiple spots where the patient's bitten all the way back down to the appliance. What that tells us is that we have not altered the vertical dimension of occlusion significantly between steps 2 and step 3. So any change that we're going to get to the positive during step 3 is mostly due to the protrusion that we had with the patient moving 3 millimeters forward. Next thing you can see is in the front where we made the marks for the patient's teeth, both the midline and where the incisal edges wanted to be, and the fact that we had to trim the anterior part of the appliance down so that that could be achieved. Our goal here is actually to remove the excess, and so the fewer beads, the better, to be honest with you, and the less deep you have to trim, the easier it's going to be. So What we find at the very beginning is that people tend to use too many beads. Too much material on here means you're going to be trimming for quite some time. It's not the end of the world, just a time factor and effort required during this stage. So less is better in many cases when it comes to this step 3. Our goal is to get rid of this excess. Remember, as we said at step 2, all moves with a knife are always done. So if it releases into the table. So it's extremely safe. The question always comes up, how much do I trim away? How deep do we end up leaving these grooves? And unfortunately, there really isn't a good answer for that right now. I always use the Goldilocks example. You don't want it too hot, too cold. You want it right in the middle. And what we have found with our patients is that it really is patient dependent. If a patient calls you back after you've been trimming on this and you've cut it down for them, if they call back and say, I keep falling out of it, it keeps making it to where I wake up because I'm coming out of the appliance, then what you want to do is have them back in and add a little more depth to the beads. If, however, the patient says, I feel locked in, now you want to actually trim away more. So the first cut we're going to make is just trimming down the side. We're going to try to get rid of it on the lingual as well, just trimming it tight to the appliance so it doesn't add any more width to the appliance at all or rob the tongue of any more space. So we're simply following the line of the appliance there. The next cuts are going to be to try to cut out some of the depth. I do like our patients to actually be able to find these grooves, but I typically like them to be able to come out of the grooves as well. So our cuts are to give them approximately a millimeter, 2 millimeters at the most worth of depth of these grooves around the teeth. Once you go back into the mouth and try it in for the patient, you're going to be able to adjust it and come back and forth until they find a level of comfort. So remember, every cut goes towards the table. If it happens to release, I want it to release into the table. Don't want your fingers in the way of any of these cuts at all. Okay. And then just lightly bevel the edge so it doesn't bother their tongue. The last thing that we do when we're trimming this is I actually want to take away some of the anatomy, especially the interproximal anatomy. So the normal way of doing that is to keep your thumb in the way, but I want you to make sure your thumb is out of the way of the blade and simply slide the knife across, reducing the anatomy interproximally, taking out some of the anatomy on the occlusal surfaces of the tooth so that the patient doesn't feel like they're locked in or having any difficulty with a wedging feeling from having the appliance in place. All these cuts are done better, in my opinion, with a blade than a burr, because once again, this material is a thermoplastic material. As soon as the burr starts running across it, it heats it up, starts melting it, little edges start fraying, and it becomes a little more difficult to polish long term. So that side looks good. Let's take a little off this edge to make it more comfortable around the front part of the tongue. Remember, every time we make a cut, it goes towards the tabletop. Okay, now we'll do the other side. The other side is the same way. We're going to trim down the buccal, take away any excess that's there. Now we'll work on the lingual, removing the excess material. Just a reminder, if the blade starts to bind at all, where you feel like you're pushing and it's not cutting well, always remember to take that blade out and get a new blade in place right away. You shouldn't feel like you're having to push too hard. Now, we'll also note that this beige color is easy to see against the appliance. And so in steps 4, 5, and 6, the key there is I have to actually remove these beads. And so I'll know exactly when I have the beads off. Okay? Now we're going to trim some of the depth that we've made away. All the cuts are made towards the tabletop. So we make sure that when the blade releases, it releases into the table. And the final thing is we're going to take some of the interproximals away. This side isn't quite as deep as the other, So that was easy to do. Then last thing I'm going to do is just bevel the edge lightly with the knife to keep it from being sharp against the patient's tongue. All right. Grab a little extra here, trim that away around the back of the teeth, and in fact, I think we'll trim this a little tighter to the lingual surfaces, just to not rob the patient of any room that they might want. So that's the trimming we're going to do at the step 3 phase. We're going to return to the patient's mouth, make sure they can find these spots, see if they have any areas that are rough to their tongue or bothering them in any way. And then if they feel like the grooves are too deep, we can always trim away a little more of the excess material. If they feel that they're slipping out and it's uncomfortable, what we typically do there is peel the beads off and replace them with deeper beads, making note not to trim so much at that point. So in fabricating the step 3 appliance, our anterior repositioning appliance, a couple of patients can be more difficult to work with. The most difficult is one with a very deep bite anteriorly. As you move forward, it's going to be impossible for you to adjust enough to actually allow them to close all the way back down and not alter the vertical dimension. So you will remove as much acrylic as you can in the anterior portion, but they will alter the vertical dimension when you add the beads. Now, I like it for each step to only make one change, as you've heard in the videos. Step 1, we do nasal breathing therapy, and step 2, we do nasal breathing therapy plus open the vertical dimension. Step 3, I already highlighted that I don't want to change the vertical dimension, I only want to have the protrusion, so that if a patient resolves at step 3, then I know the protrusive part was the key that changed. In these patients, because they're so deep, you just simply can't remove enough material and you will alter the vertical dimension, meaning you don't know exactly is it the vertical part or the protrusive part that made the biggest difference. Unfortunately, there simply isn't a way around it on some of these patients. The other patients that are somewhat challenging are those that have anterior open bites. In these cases, it may require a significant amount of removal of the splint over the second molar area. In fact, I've actually cut the molars away so that the open bite patients can protrude forward and not open so much as to not be able to get their lips together. So you've now fabricated a provisional anterior repositioning appliance. You've had the patient use it for a few days. You give them a call and find out how they're doing. If the answer is, I'm doing better, you give them another 7 days to evaluate that and call them again. So if at the end of that additional 7 days, you still get a positive response, what do? You do the same thing we do on every step. You send them home with the screening device that you've used before, high resolution pulse oximeter, CPC. If the subjective and objective data agree, then an anterior repositioning appliance becomes your control strategy. Now, there are many varieties that you can make. There is a Ferrara appliance, a Gelb appliance, an Aspen appliance. Your doctor should direct you as to the design. How do I make the interocclusal record or the bite registration for the laboratory? In fact, I use the appliance. I send the appliance that's in the patient's mouth because I know that vertical and that amount of protrusion works, and have the laboratory mounted exactly that position. That's where we finalize the anterior repositioning splint. Now, what does the doctor use now? You've gone through and worked through the protocol. You found that at step 3 the patient is doing well. You finalized by making a final anterior repositioning splint. The patient is using a piece of tape and a nasal dilator along with that. They are under control. The doctor is going to use that information to create a resolution strategy. They're going to say, how can I actually get a patient to function in that forward position all the time? And in fact, there are many ways of actually achieving that, from orthodontics to reconstructive dentistry. They may also look in and say, you know, some myofunctional therapy may simulate that, or it could be that we really need an ENT involved in this particular case. What about breathing behavior control? What about nutrition, weight loss? All those things play in. So each individual patient requires their own resolution strategy. Now, there's going to be a second response, which is, yeah, I've done it, but I still have all the symptoms that I had before. What do you do then? You move to step 4 of the protocol.